Hi, everyone. Good afternoon. My name is Sami Abdi, and I just wanted to welcome everybody who had signed up and registered and showed up for this session. Just right before we start, and I'm going to be your host and co-presenter for today. And right before we start, I just wanted to start with a land acknowledgement, acknowledging that I am at Toronto, the land of the Wendat people, the Anishinaabe, the Hadishonis, and of the Mississaugas of the New Credit, and the Métis Nations. Toronto is also home to many Indigenous people from across Turtle Island. As we do this land acknowledgement, it's important for us to know that Indigenous people lived in this land before colonization. We acknowledge that they continue to live on this land. And with that acknowledgement, we understand and recognize the rich Indigenous systems of knowledge production, governance, the spiritual and health practices that existed, still exist, and will go into the future. And with that, I would welcome all of you to acknowledge the land that you're on, the waterways that you drink from, the air that you breathe, and to recognize that there has been many nations before you on these lands and walked these lands. And what does that acknowledgement mean to you, perhaps as a settler or an immigrant or someone who has ancestry through the transatlantic slave trade? What does that mean to you in terms of being on an Indigenous land and on a colonized land, and how does that acknowledgement move us forward into the era of truth and reconciliation, real truth and reconciliation, that is. So take a minute to think through that as we go through today's discussion and as you carry out your life and your work. I also wanted to acknowledge and welcome my team members, Dr. Pamela Lees, who's a public health physician with Public Health Ontario, Caroline Bennett-Abayash, who is a knowledge exchange specialist, and Lydia, our fabulous, amazing knowledge and event coordinator, who is doing a lot of the technical pieces on the background. Pam and Caroline and myself are part of a newly formed health equity group that has been putting on a number of knowledge exchanges and webinars across the past year. And we hope to continue doing this work in a thoughtful and a reflective manner, and to continue learn as we challenge our own practices and the systems that we operate in. Also, I would like to welcome our incredibly amazing speakers that have taken time out of their super busy schedules to be with us today. That is Dr. Sarah Fennell, who is an Associate Medical Officer of Health at Ottawa Public Health Unit, and Dr. Lawrence Lowe, the Medical Officer of Health at Peel Public Health Unit. And obviously to all of you incredible people who have signed up to be with us today. And right before we just get into it, I just wanted us to start off with knowing where are you joining us from today. So we're putting out a quick poll just to see who's in the room with us today. That's amazing. So I think this is a historic event that we are not no longer Toronto-centric, and I see that Southwest have won. So thank you for all of you who've joined us from across the province. And we had a second question in terms of understanding who our audience is, and the question is around the kind of organizations that you work in. And thank you for those of you who are putting it on the chat. If your type of organization is not represented in the options that we have. So primarily our primary audience is local public health units. However, really excited to see all our colleagues from other sectors, including community health centers, hospitals, housing, academic institutions, and so on and so forth. So today, as you've read, there are 3 things that we wanted to have an opportunity to discuss: share equity-centered health unit practices to support the uptake of the COVID-19 vaccines, to highlight some of the experiences, the challenges, the opportunities that are being experienced in this area, and finally, to share some best practices and resources with all of you. The next piece is around just a very simple agenda. We're going to have a conversation around setting the context, and then we're going to have 2 brilliant presentations from our awesome speakers. And finally, we are going to have an opportunity to have an interactive conversation. We are going to do our best to address all your comments and questions. So do please feel free to type them in the message as we are going through the process of doing the presentation, and we will be spending a good amount of time addressing those questions. Next slide. All right. So in terms of just setting up this conversation, we wanted to recognize that the journey to vaccine administration is a long one and it's a complex one. And we recognize that equity is integral to all of the components of that vaccine, from supply to allocations to administration. But for the purposes of the webinar today, we wanted to focus in this in-between place of vaccine uptake and administration, and particularly to focus on ways to support marginalized and communities, including Black, Indigenous, and other racialized communities. And in terms of understanding their experiences around the COVID-19 and the inequities that have been experienced by these communities, and to hopefully prevent the same inequities being reflected in vaccine uptake. In the next slide, we wanted to be very deliberate around the use of the term vaccine uptake. Our team had the discussion around sometimes the use of vaccine refusal or rejection or even hesitancy can be a judgmental language in terms of putting the onus on individuals, and that might sometimes lead to disengagement. Also, it might not provide the opportunity to recognize the historic and current reasons and experiences of especially racialized and other marginalized communities that they have around negative experiences with the healthcare system. And also, so shifting the conversation to one where public health takes the forefront in creating trust, building opportunities for increasing confidence, and deliberately removing barriers. And just as a grounding place, or just as a starting point for our conversation today, we wanted to conceptualize this ethics, equity, feasibility, and acceptability framework for vaccine programs. And so I'm going to just go quickly through the 4 pillars of this framework, starting with ethics being this understanding and respect for individuals and communities, intentional efforts to minimize risk, the focus on justice, trust, accountability, inclusivity, responsiveness, and transparency. Second pillar being around equity and using an equity matrix that identifies potential inequities, asking why such inequities exists, and provides an opportunity to explore interventions to reduce the inequities and improve access. This matrix includes factors such as pre-existing conditions, such as comorbidities, place of residence, race, ethnicity, and immigration, occupation, gender, sex, religion, education, and income, all as factors that impact how not only people view vaccine uptake, but also how are vaccines accessed. The third pillar is around feasibility, and this particular pillar focuses on availability of resources such as vaccine supply, funding, etc., as well as creates an opportunity to integrate vaccine programs with existing programs. The final pillar in this framework is around accessibility, acceptance, I'll just say that, acceptance. And this basically things around concerns that people might have around vaccine safety, also focuses on what kind of information is available, where is the vaccine being administered, how is it going to be administered, what is the process of getting the vaccine, and that all of those factors impact people's opportunities and abilities to access the vaccine. So now I am going to be moving on and welcoming our first speaker, Dr. Sarah Fennell, that will be talking about really amazing, leading us through an amazing conversation around trust and trustworthiness and the vaccine uptake, and also the idea of vaccine questioning. Dr. Sarah, welcome.
Miigwech Samaya, and thank you to everyone that's here today to engage in this interesting discussion about vaccine questioning. And it's really that the COVID-19 pandemic has brought to the fore a lot of our discussions about vaccines, questioning, curiosity, as well as access to vaccines and barriers and other systemic issues. So next slide. Algonquin elders tell me that we must respect the virus. And to be honest with you, it's difficult for me. I'm a public health physician, a local public health unit here in Ottawa and Algonquin territory. And I also manage the COVID case and contact management team. And the last month has been incredibly challenging and difficult, yet there are many important highlights and some silver linings. And one of them is the discussion about equity and the illumination that COVID has brought to the inequities that we knew that already existed, but really put it front of papers, right in our faces. Is this something as a society we can accept? So respect the virus. It's said, do not fear the virus, but respect it. Respect is one of the cornerstones of our values, our First Nations values. When we respect something, we lose the fear of it, and attitude and behavior changes, like learning to swim. You must respect both the beauty and the danger of water, and it's the same with the virus. We need to listen to the advice, the public health advice, and the safety practices, because fearing the virus will only result in behavior that is dangerous. And an Algonquin elder has shared that with me. Next slide. COVID is also very tricky. It's such a trickster. We all know that it's spread by respiratory droplets and loves to spread in crowded places, where people are either working in crowded places, living in crowded places, areas that poor housing with poor ventilation, etc. COVID is a trickster. Trickster tales in Indigenous culture are tales of a tricky character, but also stories that have real meaning and understanding and teach us something. And COVID is certainly teaching a lot teaching us a lot about ourselves, our society, what we value, and what our post-pandemic life will look like. And I don't think it's any, I think it's very timely that anti-racism is coming to the fore of many of our discussions. Next slide. We heard from this top that language is really powerful and language really matters. And we talk about vaccine hesitancy, and it does come with a huge judgment, right? And vaccine hesitancy, as we know it, is on a spectrum, all the way from refusal to all vaccines to acceptance of all vaccines and everything in the middle. And what plays into those behavior choices is really complex. And as a public health physician, I want to ensure that people can have the choice to get vaccinated, and that's an easy choice for them to make. But it's not easy. I recognize that it is not an easy choice. And so vaccine hesitancy, we talk about reluctance or refusal despite availability of vaccine. And we've already heard that availability is also like the whole supply that we've been talking about over the last several months. It's in the news, but it's also about access, right? So access, we often think about access as physical access. I also think about access is that invisible access, which is related to systemic racism and discrimination that can't be seen by everyone except for those that experience it. And so I want us to talk about that today. And so the next slide, please. What we know about what we call vaccine hesitancy, or we'll call questioning, has a lot to do with love and the decisions we make for our children. What we know about the 3 C's of vaccine hesitancy, it was really born out of pediatrics and making the choice to vaccinate your child the easiest choice. So next slide. We have lots of guidance on how physicians and public health units can approach children and their parents in making those choices. Next slide. And so these are the three C's that we all know. It's about confidence, it's about complacency, convenience. And when all 3 of those come together, we are meant to have the perfect recipe to make choosing to be vaccinated the easiest choice. Next slide. And so in the Indigenous context, we've seen convenience as removing physical access to barriers. So removing those physical barriers, outreach, pop-up vaccination clinics. You see planes flying to northern communities so that practitioners are bringing the vaccine to the communities. That's talking about convenience, like parking lots, like transportation, about convenience. Next slide. So complacency, you have to address the actual dangers and ideas about COVID. Well, we know that COVID, some people fear COVID and some people do not fear COVID at all, but we must respect COVID and respect the virus. And so we address complacency by helping people understand COVID risks and what the vaccine can do for an individual and benefit them. Next slide. And so then here comes confidence. And so we talk a lot about vaccine confidence. And in the Indigenous context, there may be a lack of confidence in some communities based on their distinct history, but it's not universal across all Indigenous communities. For the First Nations communities specifically, we do have a legacy of nutritional experiments in residential schools and other unethical research that has been done, as well as systemic racism. Joyce Echequan's family that brought her story to the fore last year really highlights the intense racism that Indigenous people face, including when they access healthcare. Next slide. And so how do we build confidence? We're told by our Indigenous communities and other racialized communities, leaders in the community, whether a religious leader, a chief, an Indigenous physician, that can make a difference. And hearing from our own people, safety concerns, reassurance, those types of things, that promotes a confidence in communities to accept vaccines. Next slide. vaccines are really like a social thing, and it depends on it could depend on your worldview, a community or a population, or culture's worldview of how they view the world. If they're community centric or more individualistic, this influences people's decisions. And so when we look at our next slide, in the Indigenous communities, that not only do we need to address complacency, confidence, and convenience, but we need to address cultural safety. And that is what I refer to as the access, that invisible access that we can't see with our eyes, but people feel in their own bodies when they walk into a hospital or a clinic, and they feel like they don't belong. They feel that they're at risk of racism and that they're not safe. And many Indigenous people have experienced trauma related to healthcare, including receiving vaccines. So I also do primary care and speak to elders and patients about their experiences. And I've heard elders talk about trauma related to being vaccinated in residential schools and day schools. So there's so cultural safety is really, really essential. And I don't think it's just for Indigenous people or Indigenous communities. It's likely universal for all racialized communities. And then community-centric. That community centricity is so important, and building a vaccine program with the community. So it's a nothing about us without us approach. And I think we will learn more about these 5 C's in the days to come, years to come, when we look at how we rolled out the COVID vaccine and how successful we were. And so it's really important to be community-centered, to be culturally safe, and use that trauma-informed lens and cultural humility when we're approaching communities, racialized communities with vaccine programs. Next slide. So this is the last slide, just some cultural safety guidelines for clinicians, and in particular now with the vaccine, that we should be on alert for past traumatic experiences and ensure that we use that trauma-informed approaches to ensure safety and that people feel empowered and that they can make choices. Advocate for cultural safety, build relationships that create trust, working with communities, making sure that communities, Indigenous organizations know that the information about their patients is owned by the Indigenous community, and ensuring that there's access to culturally relevant resources, and that it's not all about just the vaccine and getting shots in arms, and that you see the whole person and everything around them in their entire experience with COVID. With all of this in mind, I think we'll have a lot more success in breaking down both those physical barriers to access, but also those invisible barriers to access that can't be seen or felt by everyone, except for those that are accessing the services. Chimigwich, I'm really looking forward to hearing from our next presenter. That's it from me for now. Thank you.
Thank you so much, Dr. Sarah, for providing us with these tips, and definitely for focusing on cultural safety as a tangible way those who are going to be administering and planning for the vaccines can take into consideration, and the need to center that. Our next speaker is Dr. Lawrence Lowe, who is going to be talking to us around equity-centered health unit practices, focusing on the Peel Public Health experience. Welcome, Dr. Lowe.
Thanks so much for having me, and thank you, Dr. Fanel, Sarah, for starting us off with a really great presentation that really contextualizes some of the key points around vaccine hesitancy as it pertains to our Indigenous and also culturally diverse communities. My presentation is a bit of a different tack. It's going to be talking really just about how we as a program at Peel have tried to embed embed interventions and an approach to addressing hesitancy into our overall mass vaccination plan rollout. And so I'm going to go through these slides just very quickly, and then I'm actually very excited about the discussion that we'll have afterwards. But really focusing here on essentially how we have tried to embed equity and engagement directly into our structure and then also embedding them into the operations that we have put in, while also navigating the significant uncertainty that I know many of you are navigating around the fluid timeframes of supplies and logistics and everything that seem to be a part and parcel of the vaccine rollout so far. So we'll move to the next slide, please. And so, as with many other jurisdictions, the aim of our mass vaccination plan is obviously to vaccinate. We chose a target of 75% of Peel's population against COVID-19 as quickly and as safely as possible, with priority to our most vulnerable. And I'll get into how we've prioritized and spoken about vulnerability and how that relates into interventions in respect of equity. We recognize that, at least for our population, this will require at least 2.3 million doses. And there needs to be that flexibility, as I mentioned, in terms of addressing shortages as well as potential increases in vaccine supply. And ultimately, it is about a shared responsibility and partnership across the health system, local government, but also community sectors. So vital, just working with the community as a whole, and mostly because there are certainly various factors of the rollout that are hard objective facts, for example, like the vaccine specifications, the transmission patterns that are out there, provincial directives and protocols. But then there are the broader aspects, the more intangible aspects of engagement with the community in terms of the geography, the diversity, the need for education and engagement to address hesitancy, working alongside, rather than just assuming a one-size-fits-all strategy and approach. And I think the next slide will really talk to our context, and I think it's really important to highlight that it starts with the data and the understanding of the community, right? And I think there is an understanding throughout the course of the pandemic that Peel has seen more significant spread, has been harder hit than most communities. And a lot of that is really just owing to existing inequities, existing disparities. And I often say, how interesting it is that it takes a disease that spreads from person to person to remind us that we are all ultimately connected, and that ultimately we're only as safe as all of us in our community are. So to the extent that it starts with understanding the community, it starts with understanding the patterns that you're seeing, it starts with understanding the underlying root causes, the structural and socio-demographic determinants that lead to the disparities that explain the pictures that you're seeing. We know that Peel has a significant proportion of new Canadians, of racialized Canadians, diverse race groups that are also overrepresented in our COVID case numbers. We know that one of the biggest drivers has been the fact that we have many essential workplaces in our jurisdiction, manufacturing plants, food processing plants, distribution centers. These are often, again, intersecting with the fact that it is many new and racialized Canadians who are also on the front lines and unable to work from home, unable to participate in the whole concept of staying at home as much as possible, and are actually out there assuming broader risk for our community and broader risk so that other people can actually ensure that they're not exposed to the potential ravages of the pandemic. So the most crucial step, at least that we've tried to do, is we have always tried to embed the data and our understanding of our community initially in the COVID response as a whole, but then subsequent to that, this data has also made its way into our own immunization planning, with an understanding, for example, with our essential workers. When we look at, for example, the provinces talking about phase 2, what does that mean in terms of when they say, workers who cannot work from home? What are the implications does that mean for what implications does that have for our community, where we have significant amounts of workers that can't work from home, that haven't been able to work from home? How does that then change our perspective and our moving forward in the rollout? So we'll go to the next slide then. So once you have the data and once you have an understanding of the community, it then is vital to actually develop the framework and the basis by which you will make decisions on that data. And I think to the extent we have essentially, but to the extent that we have essentially taken the provincial principles of the ethical framework, we have also added our own local factors to try to prioritize the population based on our understanding of the data and disease and risk transmission. And when we say priority populations that arise from this framework, we're referring to not only populations that are at being prioritized for vaccine rollout, but specifically starting with an understanding of who is at risk, ultimately in terms of both mortal and severe outcomes, but also exposure to COVID as a whole. So that really starts out the initial conversation of trying to figure out to characterize the nature of the risk and identify priority populations that way. And then when you actually move into the vaccine prioritization pieces, when it becomes this question of different groups set up in a sequential order or whatever the case might be, you're not just creating the sequence, but you're also thinking through knowing what you know about those groups. What are specific interventions? What are targeted, outreach, targeted materials, targeted engagements? How you're going to actually, agencies and other various aspects of those considerations to fit into the actual rollout. So it is about identifying who's at risk. It's about identifying where they might fit in some sort of prioritization framework, and then when you're actually considering the actual intervention, what you can do to make sure that you're actually reaching that population. And so these are some of the principles that we apply to our data to really understand and actually come up with both, the list of priorities, the list of priority groups, and then the things that we could to think through some of the interventions and the ways that we could reach out to them. We'll go to the next slide, please. So having the understanding of the community, having the framework by which you will apply and engage and understand and really change that understanding into an applied and into application. We actually have also then built community engagement and planning directly into our governance structure. So this is one section of our overall governance structure, but in essence, what we not seen here is the rest of our executive leadership and all the other aspects that lead to clinical logistics and operation, all those other pieces. But we've essentially created a community planning table, and this community planning table is meant to actually take that framework, take the data that we have, and actually provide strategic leadership around implementation of the mass vaccination program, considering inputs from all of the population planning tables that we've identified below. And you can see that there's a number that are active right now. The blue ones are the ones that are population tables that were identified for groups that are identified as priorities within phase 1 of the provincial rollout. And then you can see that the rest of them that are in light blue on the far right are planned for the future rollout as we get into phase 2 and some of the additional groups that will be unlocked by the provincial structure. And these, the membership of these tables include community members, it includes community agencies, it includes representatives from those constituencies in each of those tables to really ensure that we understand what are some of the barriers, what are some of the challenges, what are some of the questions, myths, all the other various aspects that then roll up into the engagement secretariat and inform the decisions taken by the community planning table, which inform the overall rollout and development of our vaccine, of our mass vaccination plan. That is also linked to an overall community equity and engagement advisory table, which you see on the right-hand side there, which also includes members of those to provide sort of an overall holistic view to everything that is coming up from the various population planning tables. And so again, this is really sort of just our recognition, our commitment, our understanding of our community, and then the framework that we've placed to actually apply our understanding in recognition that we have one of the most diverse communities in the province, if not in Canada or the world, and just a recognition that we need to be constantly in communication and dialogue with members of all sectors that are identified as priorities within our application of the framework and our data to ensure that we can tailor the program to meet specific needs of our diverse population. So we'll go to the next slide, please. And so some of the things that we've been working on as a result of our engagement with these various planning tables, there's a number of areas that we identify as sort of challenges and risks that we need to mitigate, at least in our efforts to push towards equity. One of the big things is the data itself. So as we're getting to vaccination, we know that the provincial vaccine systems, information systems, the access to those systems, we need to be able to have more and more access to data, and we need to make sure that those systems are actually capturing the appropriate data that will allow us to act on and continually refine and evaluate the vaccine rollout as it's occurring. So we have been certainly asking and working with our ministry partners, making requests around how do we start capturing socio-demographic data around who's getting vaccinated? How do we start capturing, all these other pieces? And so we know that it's really exciting that there is a provincial mandate for that, but to the extent that we can get even more, data that allows us to target things more precisely, that is an important risk that we need to manage together in respect of the data, the technology. We know that allocation for hotspots is another piece, to the extent that places where there are higher rates of transmission have higher risks of outcomes, exposure, etc. Working with the communities to understand how we actually address that within the overall framework and our understanding of our community is another risk that we're working and managing through that community planning table that we've identified. And then, of course, the two big things that we need to work with in recognizing the equities and disparities that continue to drive transmission and also drive vaccine hesitancy really speak to the need, the last two challenges and risks. We do need to continue advocating for supports, at least for people to adhere to precautions and public health measures, because ultimately part of the success of the vaccine program is also going to be addressing the disparities we see in transmission, the disparities that we see, for example, around essential workers, our racialized populations that are bearing the brunt of the disease. If we can try to keep rates down, if we can try to provide supports, that is an essential component to also guaranteeing the eventual success of the vaccine program. So that's why we have that there as something that we're constantly thinking about and working with our community partners on, as well as the promotion of vaccine confidence through taking the feedback that's received to a community planning table and planning appropriate communications, outreach and engagement, and accessible forums that can allow us to actually hear from and speak with these communities in direct, two-way conversations. Those are all aspects of the rollout that are actually being managed. These are some of the challenges and risks that are essentially being managed by that community planning table and embedded throughout the overall response that we have here in Peel. And we'll go to the next slide, please. So this is just an example of some of the communications and outreach that we've done so far. So we have actually partnered with numerous ethno-racial task forces and also the overall community response table to really work on building awareness and trust and correcting misinformation around the vaccine at this point in time. Also tried to manage expectations, encourage patients, especially for people who aren't immediately getting vaccinated right now due to the supply shortages, but letting them know that they are not being forgotten, they are not being left out of the role altogether, because we do want to make sure, some parts of it is certainly addressing hesitancy. Some parts is also really just addressing overall expectations, knowing that there are members of the community who are willing to get vaccinated, but we want to make sure that we're, when the time comes, the barriers are addressed and they are actually advised of the time where they can actually get vaccinated. Just right now, obviously, the challenge is being supply and the limitations there too. We also have a roster of diverse health professionals and staff that have been hired. We've put out, we've hired with an eye, for example, for different languages, for different cultural approaches. Those have all been considered throughout our hiring process. In what has been a significant hiring process, we've already hired over 900 professionals to work at various mass vaccination clinics, but had always embedded that aspect and lens in the course of hiring. And then also linking it with other strategies that are already underway, such as the provincial high priority community strategy, where the community health ambassadors that have been recruited as part of that strategy are also going to be equipped and embedded within the overall mass vaccination rollout to essentially continue to be our ears on the ground, as well as continuing to share information and address concerns that the community may have going forward. So we'll go to the next slide. So, all of this is not without challenge, right? And I think, while I've laid out what the utopian view is for us, we do recognize that our health unit is still dealing with COVID-19 and numerous other challenges. So, time, resources, coordination, these are all obviously ongoing challenges in terms of balancing the ongoing COVID-19 response, as well as vaccination and day-to-day service delivery of critical programs. But ultimately, to the extent that we're really trying to make sure that that we are able to stick to the game plan that I've identified as much as possible, hopefully that will continue to stand us in good stead as the vaccine rollout starts to reach more and more of our diverse community. So we'll go to the next slide, please. So ultimately, we are at the start of a journey, but I always tell people, like, again, it starts for us in our health unit. It starts with the data, starts then with it moves then to the framework and application, and then it moves then to actually embedding it within your processes, within your governance, within the various tables that continue to inform the rollout. And so, to the extent that we are still trying, and we won't always get it perfect, and I always make that point clear, but we always try our best. And I always tell people, if someone has a problem with public health in Peel, they can come talk to me. If I'm the public health problem in Peel, then they need to talk to the chair of the Board of Health. But long story short, we have really made it a commitment to prioritize and to be a listening organization, and to be an organization that has actually embedded equity and engagement as far as possible within our vaccine rollout and structure. So thank you very much, and I'm looking forward to the discussion.
Thank you, Dr. Lawrence. It's wonderful to see the concerted effort to embed equity, as opposed to it being a tokenized topic or an afterthought. So it's wonderful to see that it is part of your planning and how you implement this work. I'm going to be inviting my colleague Caroline to provide some support around the discussion and the questions that have been submitted by all the amazing people who've signed up. We've got a lot of wonderful questions.
So hi everyone. I definitely thought of new questions. Thank you so much for that. We'd asked people to submit a few questions ahead of time. And so just in the interest of having a more interactive discussion, we thought we could just ask the speakers to speak to the first question, and then we can take comments from the audience and questions. And if we have time, we can come back to the other two. So really the question for both of you would be, what are ways to support people who are experiencing homelessness, don't have ID, including OHIP, to make sure they access and complete their vaccinations?
Sarah, do you want to start first?
Sure. I'll address those that are experiencing homelessness. So here in Ottawa, Ottawa has a population of over 1 million. We do have an inner city, and we do have, sadly, a large population of individuals that don't have homes, are living on the streets and using having to use our shelter services. Over 25% of that group is Indigenous. And so you can imagine that the experiences of those individuals can be one of a past history of trauma, racism, of course, and so what we've done here in Ottawa to address or to rolling out a vaccine, pardon my home phone, to address any of those a trauma-informed approach to vaccine rollout and those that are experiencing homelessness is to work with our partners. So that's one of the beautiful things about public health, is that we understand the impact and the importance of collaborating both with our community and with partners. And so, of course, we don't have in public health, local public health, we can't do this all by ourselves. And so in Ottawa, we've partnered with Ottawa Inner City Health to ensure that we have a successful vaccine rollout in the homelessness population. And we have taken their lead, our partners, our trusted partners, trusted by the clients, to be the person-facing center of the vaccine rollout. We have a beautiful quote from one of the people that just recently received a vaccine through one of our city shelters, who said, thank you very much. This is the best thing you've done for me in the last 2 years. So, so I'm feeling very hopeful that we'll soon be able to overcome the incredible outbreaks that we've had in our shelters here in Ottawa. Can't wait to hear from you, Dr. Lowe. Thanks.
Yeah, thanks, Dr. Fadal. And so, I mean, to the extent that I think you've covered the situation for people experiencing homelessness, you know, I would say, you know, for those who don't have OHIP cards, my understanding is just that other photographic identification are pieces that may be used in those situations. I think to the extent that someone who doesn't have OHIP cards has broader equity issues, you know, in terms of access, I think rectifying the situation that they don't have an OHIP card if they're OHIP eligible would be the first and foremost situation. But obviously, if there's other questions of their eligibility and it is just a matter of accessing the vaccine, you know, I think the system is designed, hopefully, to allow access with other photographic identification as well.
Okay, thank you, everyone. The cursor is moving around, but I'll hand it over to Dr. Pamela Leeds, who can just go through the questions with us. And Pam, just let me know if you want me to go back to the other slide to the 2 extra questions. So we encourage people to ask questions, and also some questions might be things you have responses for as well as attendees. So please share with everyone, that'd be great.
Great, thanks, Caroline. So just looking in the chat box, there are a couple of comments, specifically thanking Dr. Lowe for your work in the community. So kudos, and also for all of the panelists and Sammy, our host, around the discussion about language and language mattering for this discussion. So one of the questions here was from Hamilton. So a concern raised at the Hamilton Vaccine Readiness Network is the language and length of the sociodemographic data collection consent form by Ministry of Health. So that was our webinar yesterday, and whether Public Health Ontario will be reviewing and discussing with the province ways to make the consent form more user friendly. So this is a bridging question between this session and the one we had yesterday, and we can bring that back. I know somebody had raised that on the call. I don't know if the speakers want to comment on their experience or thoughts on implementing the provincial consent around sociodemographic data collection with your vaccine program.
Sorry, so you're talking about the that specific form that you were talking about there, Pam?
Yes, and yesterday, Yolande from the ministry had said that it is required that the full consent form be read out because it's a legal document. So I'm wondering if you do have any comments on the practicalities and the support for your staff in the vaccine program around administering the consent with groups, because it is an aspect of the engagement.
Yeah, I mean, I think to the extent that you know, the form is as prescribed, and I think it's standardized for the purposes of making sure that that the appropriate information is captured. I'd have to confirm with my team, but I believe that the extent of training is really just impressing upon them the reason why it is the way it is and the reason why those questions are being asked. You know, I think it's in terms of trying to make things more user-friendly, it's always trying to strike that balance between making sure that we are collecting usable data and also being able to actually really capture data that can then help to optimize the program, especially in the way that we want to make sure that it is reaching the priority populations that do need this support versus you know, efficiency and effectiveness. But you know, I think to the extent that our training impresses upon our team, you know, the importance of why that data is being collected, you know, I think it just is a matter of trying to figure out how best to make sure that then gets implemented in the actual course of the rollout.
It's Sarah here from Ottawa. When we started our rollout for the socio-demographic data that we were collecting on those that tested positive for COVID, before we went to full implementation, we spoke to our partners, both Indigenous and African Black Caribbean partners, to advise them and further to get their feedback and support on asking these types of questions. So I think it's really important, again, that we work in partnership when we ask very personal questions of this type of nature. Of course, in the Indigenous context, there are many people that are reluctant to provide information about their race. And that stems from systemic discrimination and racism experienced in the healthcare system, social system, legal system, education system. And so we do our best. We understand the importance of having this type of data to understand the inequities in our communities. And so for that reason, it is really important to work with our partners to help us disseminate the reasons why we'd be collecting this type of data. Thanks.
Great, thanks so much. There's another question here for the presenters about your views on making vaccines mandatory for people working in healthcare environments, so long-term care, hospitals, where they're looking after individuals who are potentially compromised from a health perspective.
Immunocompromise is certainly one of those. I believe, is captured in some of the phase 2 conditions that had actually been announced by the province just recently. I think to the extent, and Pam, sorry, you were saying these are specifically healthcare workers, or?
Yes, and the question is about mandatory vaccination.
Oh yes, of course. I think this is more of an ethical question than an equity question at this point in time. And I wouldn't presume to speak for the experts on this one, including Max Smith and the rest of the ethics piece. But I really do think, to the extent that we are trying to strongly encourage or strongly recommend vaccines, both as a way of not just returning back to normal life, but as a means to actually protect our most vulnerable. I think the best way I would phrase it is the act of making vaccines mandatory is more of an ethical legal question. But I think the course of trying to ensure that population is vaccinated is an equity question. Just the actually getting to making sure that healthcare workers who take care of those populations are vaccinated is an equity question, because it does mean protection indirectly for the populations that they do serve, who we do know from the data, again, starting from our understanding of the data in our community, are at greater risk of more severe and mortal outcomes with the disease in question.
Well, this is a really challenging question, and I know that one that is happening around the world about mandatory vaccines for healthcare workers. And I'd say that that it's similar to other public health enforcement acts that we do to reduce individuals' autonomy and choice for themselves. And that's not an easy thing to do. And as Dr. Lowe pointed out, that we need to rely on our ethical principles and legal to make these types of decisions, and they're not easy to make. And so when you are removing or restricting someone's autonomy, you have to balance that with the harm or the benefit to the community, as well as being really transparent of why that would be the option that that public health would recommend, as well that there has to be some sort of principle of reciprocity, that someone would have their autonomy restricted for the greater good of a community, and for that there should be some sort of reciprocity towards that individual for that. But it's not an easy decision to make. and so time will tell how we'll strike the right balance between autonomy and the other public health ethics. Thanks.
Thanks, Sarah. There's a question here for you, Lawrence, about the membership and role of the community response table, if you could describe further.
Absolutely. And the reality, the thing I should say at the outset is there is both the community planning table, which is within within our mass vaccination program structure, and that is made up of community agencies, usually linked to the high priority community strategy, as well as members from across the healthcare and health sector, across the regional government, as well as other civil society. And so we have, we have engaged, for example, ethnocultural task forces, Indigenous groups and task forces. They've all been sort of, there is representation around that table within the vaccine program. There is also a community response table, which gets a bit confusing. That was actually created at the outset of the pandemic, where we also brought together pretty much, that was actually our human services colleagues, our social service colleagues, who basically brought together all of the community agencies that interface with the Region Appeal, just to keep them up to date and to hear from them about the impacts of the pandemic on their community and on their service offerings. So there are two different tables. One of them is the embedded piece in there showing our commitment, as I mentioned, to the equity and diversity of the vaccine rollout, and it does have linkages and interfaces with the broader community response table that's part of our overall pandemic emergency response.
I'd also add from Ottawa, we developed a community engagement group earlier on in the pandemic to address high priority neighborhoods and racialized communities that were at higher risk of COVID. And building on those relationships, we've continued with those groups on culturally relevant approaches to vaccination. So again, the theme of partnerships and working together is really essential for any successful public health program. Thanks.
Thanks, Sarah. There's a longer question here I will paraphrase about reach in versus reach out strategies. And are there equity reasons for using a reach in versus reach out method of vaccine scheduling? So this would be where people have to actively book their own appointments, or whether someone is calling them to help them book appointments. So maybe Sarah, I'll ask you first if you want to comment on that.
Well, you can see that the human resources required for the reach out approach might be intensive and best be done by community partners. I suppose that the way we're doing it in Ottawa is the reach in approach, where clients book appointments with us. I suppose if you think about evidence approaches to successful vaccine programs, there are provider elements of that. And when we get to a point where our primary care or other hospital clinics are able to book vaccines for their own clients, then we probably will see that that reach out approach is very effective. And so what we need is more vaccine distributed within our community so that we can leverage those types of booking methods for clients.
Yeah, and I would just add, I absolutely agree with Sarah's perspective. It is very labor intensive to reach out. I will say that we have employed reach out for specific priority groups just at the outset. For example, when we were unrolling, a specific group, when we did seniors over 80 plus, for example, we did an initial reach out through primary care networks to identify potential seniors that could then come as almost like a bit of a soft launch or pilot to make, crash test the clinics, make sure that they are, set up for seniors, all those other pieces. But then obviously with the vast majority of our population, and the extent of it, our focus has really been on engaging with community agencies to push people towards a reach into our health unit and the booking systems that are available. And whether it's stuff like providing language support or translation support, you know, when using the website or whatever the case might be, those are some of the ways that we're essentially trying to give a bit of a push to the priority population so that they can still access it without necessarily having to reach out to them directly.
Yeah, similarly here in Ottawa, we've again engaged our community partners to help us, community health centers and other community organizations, to call clients they know that would be eligible and support them to book through us. So I guess it's a blended model of reaching in and reaching out. Oh my gosh, I think I just used a line from a song, and Lawrence might start singing.
Luckily, we're at 3 o'clock, so I guess I don't have time to sing a song right now.
Next time, Lawrence. Sammy, I'll turn it back to you. Seeing that we quickly came up to our time for the session, I'm sorry there's a couple of questions we didn't get to in the chat box, but great engagement and good questions from the audience. I'll turn it back to you, Sammy, for the wrap up.
Yeah, thank you so much, everyone. I think we will try to see if we can provide some answers, reach back to our speakers and address some of the questions around, especially around evaluating, measuring, and metrics for accountability. I think that is a really key point to ensure that we are addressing that piece. Just right before we close off, we wanted to just touch base with folks who are on the line. If there are anything else that you would like us to consider for future webinars around equity, what might be some emerging critical conversations that you would like us to host. So if you don't mind dropping us a line in the chat box, we would greatly appreciate it. Again, thank you so much, Dr. Sarah and Dr. Lawrence, for really taking the time to spend what day is it? Your Wednesday with us, and really having this engaging conversation and amazing presentations. Yeah, thank you, everyone. If people can just maybe let us know if there are other things, and we will be sending an evaluation link that you can provide us more feedback around what we might be planning next.